Good afternoon, everyone, and thank you for joining us for the November 2021 Telehealth Learning Collaborative hosted by Adirondack Health Institute and Fort Drum Regional Health Planning Organization. My name is Nancy Del Mastro, and I'm the Telehealth Project Manager at AHI. We have a packed agenda today. We're going to start by hearing from our state partners for any state regulatory updates. We're going to turn it over to Anthony Gemrozzi at CMS to speak about the upcoming physician fee schedule for 2022 and the telehealth updates in there. And then we will be hearing from Dr. Yili Huang and Sandeep Kapoor of Northwell Health to talk about telepain management. I'm looking at our attendee list and I don't see our DOH partners on just yet, but I do see Amy Smith of OMH. So I'm going to ask Amy if you would like to begin with our Office of Mental Health updates.
Sure, thanks, Nancy. And I believe that Kendra and Megan were not available. They both had something come up last minute, so I don't think DOH will be on today. Okay. But just wanted to give a pretty quick update from OMH. So we have moved forward with getting our updates to our Part 596 telemental health reg pushed forward as an emergency regulation. And we did get all the sign-off and approvals that we need. It's possible that it may have posted today, although I don't have confirmation of that quite yet. But we're looking for that to come out very soon. And then we'll be making some updates to our guidance documents. We'll also be making some updates to the commissioner's waiver that's in place. And we'll be working on building in a grace period for any providers that have not yet been able to apply for permanent telehealth approval so that they will have time to be able to do that so they can get in compliance with the regulation changes. But we'll have some messaging coming out about that in the very near future. So that's our updates at OMH.
Thank you, Amy. So we're actually going to go ahead and move to our Medicare updates since DOH and OASAS are both unavailable today. And we have Anthony Gemrozzi on the line. If you want to unmute and provide any CMS.
Yes, I'm here. Hi, good afternoon all. Yeah, my name's Anthony Gemrozzi. Everybody calls me Tony. And I work for the local engagement group at the CMS regional office in New York. And basically what I wanted to do was give you a little outline of what's in the final rule for the 2022 physician fee schedule regarding the provisions of the Consolidated Appropriations Act and the expansion of telehealth in providing mental health services. So as background, just remind you that, the originating site for telehealth as far as the section of the Medicare law that existed before limits the originating site for most telehealth services to a healthcare facility or a healthcare setting and in a rural area. So there's a geographic and a place of service limitation in the law. Excuse me. The one exception is for services for the someone with treating as a substance use disorder or a co-occurrent mental health issue. The patient's home can be the originating site, and the geographic limits don't apply. This is basically, Medicare covers opioid treatment programs. With that as background, what this provision of the Consolidated Appropriations Act does is it allows the Medicare originating site for telehealth to be the patient's home if the services for the diagnosis, evaluation, or treatment of a mental health disorder And it also allows the originating site to be outside of a geographic rural area. And there's two provisos. Proviso 1 says that at least within the 6 months prior to the mental telehealth service, there was a in-person contact between the patient and the practitioner rendering the telehealth service. And it also says that according to thereafter, at such times as the secretary determines appropriate, a in-person telehealth service must be provided. So that's the law. What the conditions of the final rule are is that there has to be an in-person service with either the same practitioner that provides the telehealth service for the mental health disorder, or a member of the same group with the same specialty and subspecialty within 6 months of that telehealth service. And this doesn't apply where the existing law provided like coverage for the mental health telehealth service. So in other words, like say the originating site is a health facility in a rural area, this 6-month proviso does not apply. Also, if the service is for the treatment of a substance use disorder or a co-occurring mental health disorder, the 6-month proviso does not apply. With regard to the how often do telehealth, in-person services have to be provided thereafter, in the proposed rule, they were saying that within 6 months after the telehealth service, there should be an in-person service. This went out for comment, and based on the comments they received, they broadened the requirement that as a general rule, there should be an in-person service 12 months, or at least within 12 months after a telehealth service. But there's an exception criterion too, where basically I'm going to read this to you from the rule. We are finalizing our proposed policy with a modification to require in general that after the first mental health telehealth service in a patient's home, there must be an in-person non-telehealth service within 12 months of each mental telehealth service, but to allow for limited exceptions to the requirement. Specifically, if the patient and the practitioner agree that the benefits of an in-person non-telehealth service within 12 months of the mental health service are outweighed by risks and burdens associated with an in-person service, and the basis for that decision is documented in the patient's medical record, the in-person visit requirement will not apply for that particular 12-month period. Okay. Another little wrinkle here is what's a patient's home? Like if a person is living in a shelter, or has temporary lodging, or maybe doesn't want to discuss doesn't want to hold the visit in the home, wants to go into a car, for instance, to do the telehealth service. The rule allows for flexibility in regard to that also. Another thing that I wanted to talk about is audio-only services. And here, the rule allows audio-only services under these certain conditions, that the provider of the telehealth service can do audio and visual connection, okay? But the beneficiary, the patient in home, doesn't want to or can't do a audio visual connection. And basically the yeah, the telehealth services can be provided by audio-only services, and this again, the diagnosis, evaluation, and treatment of a mental health disorder. What else? Oh, federally qualified health centers and rural health centers. Basically the same rules apply to them, and they can provide mental telehealth services. All of this is, after the pandemic, of course, and basically the same rules apply. But in the case of a rural health center or federally qualified health center, you would bill it instead of as a telehealth service under that G code. You would bill it as a regular mental health visit with modifier 95 to say it was done by telehealth. So any questions?
Thank you, Tony. I don't see anything in the chat or Q&A boxes just yet. If any of our attendees do have any questions regarding these rules,
Yeah.
Oh, Lori did ask, is there a link to this guidance for CMS Medicare? Yes, I will be providing that in the notes that come out either this afternoon or tomorrow morning, Lori.
Okay. Yeah. Basically what I'm doing is I'm summarizing a 30-page section of the double-spaced rule as it appears on the Federal Register. It's in there, out there for public inspection, and this material begins on page 157 of 2414. Okay. Well, the other thing that I'm interested in, and you see my name up there, Anthony Jamrosi. Okay. My email is anthony.jamrosi@cms.hhs.gov. And I'm interested in hearing anything that might be a pinch point in this. Like, for instance, the person that does the telehealth has to have done an in-person visit, or someone in that person's group has to, with the same specialty, has to have done an in-person visit. And like I'm wondering what problems that creates. Given that all of this is going to come into effect when the public health emergency ends, and we're looking at ways to sort of soften the fall from the cliff. So we're interested in any feedback. Thanks very much.
Thank you so much, Tony. I will put your email in the notes that we send out, and we'll solicit any feedback we can get for you regarding that.
Okay, thank you. So I'll go off now.
Great. Thank you so much again.
Okay.
With that being said, at this point, I am going to turn the floor over to our presenters from Northwell Health. One second as we just transition. Dr. Kapoor and Dr. Huang, the stage is yours. And again, to our participants, feel free to put any of your questions or comments in the Q&A or chat. Thank you.
I'm muted. All right. Can you guys hear me? All right. We can see. Thank you very much for unmuting me. So thank you very much for the kind invitation to myself and Yili to come and speak to you about a really exciting program that we've been able to stand up here with multiple partners and stakeholders, really revolving around a debilitating disease process that is highly stigmatized and unfortunately still not taken care of as part of usual care. So today our presentation really is about delivering hope and addressing pain care via partnership. Let me just start off by saying that both Dr. Huang and I belong to the system-level opioid management steering committee that was created about 5 years ago to universally or to stand up solutions to address the opioid crisis. And when you look at the left hand of the slide, these 4 buckets, you see 4 simple domains in terms of what health systems can do differently. And through this exercise with IHI, the right-hand side of the slide got populated. And what we realized very quickly is how many touch points we were getting it wrong as an industry, as well as the largest healthcare organization in New York State. So working with partners and stakeholders, we want to describe to you a solution that has been extremely popular, as well as effective in making sure that patients aren't left to suffer on their own. Before we get to the actual program, I would like to take a step back and at least talk a little bit about the why. Why is it necessary to develop strategies around pain care that include telehealth? And I think the best way to frame this is really looking at the value of building processes so that we could acknowledge what the patient population is going through. Now, many folks that may be dealing with a pain issue have dealt with shame, guilt, and stigma. They've also dealt with healthcare professionals not approaching them in a holistic manner, but in a combative and judgmental manner. So I want everyone to just think about the power that telehealth, as well as reframing this conversation, can bring to the table, where not only can we hear what someone is going through, but we can take a moment to appreciate, acknowledge, and affirm. We can be a conduit to better understand that when someone is feeling hopeless with a chronic illness that is, again, debilitating, that creating opportunities via telehealth can actually bring some light to the equation. And I want everyone to think for a moment, if you have ever suffered from a chronic illness or even an acute illness, what did it mean when someone paused and stopped and made eye contact with you and said, you know what, I value what you're going through? You probably felt supported, heard, relieved, safe, accepted, connected, and trusted. So with all that in mind and taking lessons learned from our ancestors, I would like to pose this question to everyone, and I want everyone to take a moment to self-reflect. So Dr. Martin Luther King said, life's most persistent and urgent question is, what are you doing for others? And as a group of individuals on this learning collaborative that work in healthcare, we do a lot for others. However, systematically, if we remove the word others and replace it with those dealing with pain issues, systematically, it may be a difficult question to reflect upon. As an industry, it may be a difficult question to answer, but we need to answer. Our strategy here at Northwell is threefold. Develop education and programming so we can garner motivation from our healthcare professionals to get to that level of comfort to serve as conduits of hope for this disease process that can be debilitating for far too many. The real issue is the public health crisis. We, in this past year, have seen the most drug-related deaths in any given year before. 93,000 plus drug-related deaths, majority due to opioid overdoses. Folks, we have a call to action that we can prevent the progression of this trend by providing quality and timely pain care. Now let's talk about the prevalence for a second. My 11-year-old can talk to you about diabetes, heart disease, and cancer. However, there's 100 million people dealing with chronic pain, and we still have a void in our education and our approach around this topic. And part of it is because we keep playing something called the blame game. Let me explain it. There is no shortage of players. Big pharma, the hospitals, the pharmacies, Press-Ganey, Joint Commission, the federal government, even the criminal justice system when it comes to the pain crisis. But the only people left to fend for themselves as we play this blame game are the individuals, our families, our patients struggling to find some recourse to the pain that they're dealing with. Let me explain this blame game in a little more detail. That lack of accountability underscores a lack of ownership, perpetuating a lack of motivation, which fosters what we see, a lack of action. But we're here together to talk to you about how we can act. And the one realization we have to come to, that the road to recovery is not a straight line. Our expectations may be to point A, point B, but someone dealing with pain, it's a complicated equation. And if we can stand up processes to reduce the complications, to reduce the barriers, then we're ahead of the game. We're able to, in a person-centric manner, care for individuals that deserve to be cared for. So with that said, the telepain program that Dr. Huang is going to describe to you allows us to reframe and act and to advocate, and also to garner motivation to act, to partner, to innovate, and to correct, so that finally for this disease process, we can provide care and social justice indiscriminately. Just think about it. A telehealth program can serve on a journey for us to actually correct the wrongs or right the wrongs of the past and replace that despair and hopelessness that's so prevalent in this space with compassion and equity. So though this journey is new, we are starting off with some checklists, but we're actually using a compass that's deep student compassion, acceptance, respect, empathy, and justice. And hopefully after today's presentation, we can find opportunities to partner so that we can continue to humanize this topic, destigmatize it as it deserves, disrupt those industry norms that we've been forced to follow, accept pain as the healthcare issue it truly is, build partnerships amongst ourselves, our patients, and our communities, and finally, serve as conduits of hope for a debilitating chronic illness that's still hopeless for far too many. So with that said, I'm going to hand over to my partner, Dr. Huang, to kind of walk us through the Northwell Health Telepain Care Center. Yili?
Thank you, Dr. Kapoor, and thank you everybody for having us here really to describe this unique journey that we've been on. To Dr. Kapoor's point, this is really a team-based approach, and we've been very, very fortunate to be able to connect and really leverage the skills that we all have here at Northwell. So I'm excited to share this with you. Next slide. So we really started off very, very personal here, and we thought, if we had a loved one that needed quality pain care in the next few days, us all having, being part of this Northwell family, did we know who to turn to at Northwell? And as you all know, Northwell is one of the largest healthcare systems and largest private employer in New York State. And here, we were struggling with this as we met in our opiate management steering committees, trying to identify this. And next slide, please. And these are our challenges. Really, what happens is access to pain care is a challenge, but access to timely pain care is more of an issue because, unfortunately, if we know this right now, Dr. Kapoor had alluded to our growing opiate epidemic, that if patients get established with improper pain care and potentially opiates, there is as high as a 20% chance that patient may misuse down the line. Really, this is an issue that is exacerbated by the pandemic, and we have the numbers now to unfortunately show that. And as you all know, there's great legislation around this. There's very common sense guidelines and requirements to be fulfilled to ensure that our patients get quality pain care. The problem is practice burden on our healthcare providers. Our healthcare providers who are dealing with everything else and having to really become experts on pain care when that is not their training, that's not their background. And essentially, leakage is a huge issue when it comes to quality pain care, because we see this, our patients bounce from emergency room to emergency room, from practice to practice, really nobody taking ownership in caring for the patient as a whole. Next slide. So here's really the opportunity. And we've seen this through the pandemic and through the expansion of telehealth, that, especially through the pandemic, patient satisfaction with telehealth visits has been higher than patient satisfaction with inpatient visits. Access to pain care can be leveraged with telehealth. And, what I reference here is actually a study from at MGH that show that basically established telehealth, and this was in 2017. This was pre-pandemic, where established telehealth visits to Martha's Vineyard, where a physician at MGH took care of patients at Martha's Vineyard for over 200 patients, and then took monthly trips out there to care for them. And it's shown that it's possible to kind of develop this rapport, and this is via for pain care, and treat the patients for those instances when they're out there on the island. And another thing is through the expansion of telehealth, now we have great and creative guidelines and data around how we can leverage telehealth. Here's an example of something called a Sperling's test, where we have a patient via telehealth do a physical exam on themselves to elucidate whether they have cervical radiculopathy or some type of nerve condition in the neck. And again, all these creative things and guidelines are coming on through our medical associations. And at the same time, there's data demonstrating that if we kind of leverage the foundation of telehealth and then use inpatient visits judiciously, in-person visits judiciously, such as for procedures, it works. So here's a study demonstrating for spine procedures, which is a large percentage of most pain care, that over 90% of these procedures do not change after an initial telehealth visit and then an in-person visit. So it shows that we can make the right medical decisions when it comes to patients when we leverage telehealth. So this is our solution, and we are so excited to really talk to you about this and really get this rolling off the ground. Together as a group, we came together to form the Northwell Health Telepain Care Center. And the idea was very simple. You know, we have these challenges, we have these opportunities. How do we leverage telehealth to marry them together and meet these challenges? So what we've done is really we created this infrastructure where a referring provider can refer a patient, and we built a team of fellowship trained pain management physicians through our health system. We've connected them through the vast regions of our health system through 4 or 5 counties. And then we essentially say, hey, for the providers referring the patients, we can leverage this infrastructure and see the patient via telehealth within 72 hours. So the patients are seen as a new patient telehealth visit, and we establish care, and we also built in care navigation around this, where now there's multiple touch points where our telehealth coordinators can now reach out to the patient via 15, 45, 60 days after, to then follow up with care, so that again, these patients are not lost to follow-up, are not lost to leakage. If via this telehealth encounter, we think that the patient medically needs to be seen in person, then we can work with the patient to either get them in person to our office, or leverage some of our other pain physicians either via the telehealth program or partnership in our local regions, where we can get them in to now see those providers and those pain physicians in a timely fashion, usually a week. And similarly with procedures, if patients need procedures, we can either work with the patient to have the procedures done by this telehealth physician if necessary, or done locally through our infrastructure and our locations. Similarly with a lot of the other downstream care necessary, as you see here, it's really kind of like the easy button for our referring providers to put them in touch with a board certified fellowship trained pain management physician. Next slide. So the key components are important. Care navigation we talked about. Care navigation is really key, because what happens, and as you'll see, is that unfortunately, if we don't have the care navigation of tying the patients in, patients then start bouncing around again because they're looking for that care. So reminding the patients, and a lot of times, especially when it comes to pain, it doesn't bother you until it bothers you. So when it comes to patients who deal with chronic pain, but in an intermittent basis, having that proactive rather than reactive visit and consultation is key. So having our care navigators reach out to the patient and then connecting us with the patient to, again, being proactive with their pain care is very important. We've tied together, as I had mentioned, leaders within pain care within our organization from very diverse backgrounds. Pain management physicians come from many backgrounds, came from anesthesiology, physiatry, neurology, and we have representation from all of these service lines, as well as representation through our vast geography, all the way from Suffolk County, Nassau County, Westchester, and Queens. So we have that representation from our pain physicians within the telepain program. The very, very important thing that we had to discuss, very important topic and key to quality pain care is telehealth and controlled substances. It's really not standard of care, and there's regulation around the prescribing of controlled substances via telehealth. And this is very important, especially when you think about pain care and the potential of utilizing medications like opiates. So what do we do? And this is key. The key to this is that we educate our referring providers, and we start this in a pilot stage where we educate our referring providers around the fact that there is specific regulation, and they cannot expect to refer a patient and for us to then take over any of the opiate prescriptions or initiate any opiate prescriptions. What this consultative service is really to allow us to connect via our vast geography, via our vast network of different specialists, to connect and build a team and leverage telehealth to build a team that serves the patient. So how does that work? Many times, patients do not need controlled substances. And it works very well for the patient. They don't even get started with controlled substances, and we do not start down that slippery slope because we have the expertise. The pain management physicians within the telehealth program have the expertise to really start that quality pain care initially. Now, when patients are on controlled substances or opiates or need controlled substances and opiates, we developed this team where we can now do the due diligence, to fulfill the regulatory requirements that we talked about that adds to the practice burden of the primary care physician or any of the other referring providers, and ensure that everything is done, that we are providing quality care without the prescription of the controlled substance. Send a message back via our infrastructure of leveraging not only our EMR, but also we utilize RECAP to build a external messaging and data collection platform where we can automatically send messages back to our pilot referring providers and give our advice and consultative advice around the care of a patient. So that may mean, hey, this is what you have the patient on is appropriate, we'll continue it. Or it could mean, hey, let's start thinking about weaning for something that's, non-cancer pain that you're treating the patient for because maybe they don't need these opiates. Hey, let's think about other multimodal approaches, things like that. So the key here is to set that expectation that it's an easy button, but it's not the easy button that you press and all of a sudden, the controlled substances are cared for by somebody else. And that's very, very important. But once that message comes across, we found that the patient care improves. And we're able to start this idea of really multimodal pain care, using different avenues and different treatments to help a patient with pain. Pilot site championship is very important. We have a hub and spoke model around this, where we really leverage site champions within our sites. And speaking of what we've done, so again, looking at our pilot data, we have seen, and this is This is data from last year to the summer of this year. We've seen 128 discrete patients. Now that number is higher now. It's about 150 or 160. Next, yeah, and about 90% of them have requested an appointment, as you'd imagine, within 72 hours to help with their pain. We've captured about 64% of those for telehealth visits, and another 80% of those have arrived for telehealth visits during that time. In addition, and this is very important because this is something that you know is important to this, because patients are required, if patients need interventions, they may need to travel or they may need to change providers. That being said, we have been able to when appropriate, do 17 out of those 84 out of those 70 patients that we're seeing, 17 pain procedures for these patients, which is a fairly high capture rate when you're talking about potentially traveling an hour or so to get a procedure done. This is the demographic of where the patients come from, and I think that's a sign of really where our referral sites are from, our pilot sites are from. So our pilot sites are our Division of General Internal Medicine, which is mostly based in Nassau County, as well as one of our acute care sites, LIJ Forest Hills. So this is very important, that we found in our data that 64 of those percent of those patients that we've seen have never seen a pain specialist before. So now the Telepain Care Center is the first point of contact for pain management for these patients. And these patients are patients who obviously need pain management. Next slide, please. Instead, we found that 45.7% of these patients are utilizing other methods, using urgent care, emergency departments within the last 30 days to care for their pain. So, they see their primary doctor, they may see other specialists. They've never, the vast majority of them have never seen a pain specialist before this, but instead they're going to the emergency room to care for their pain. And unfortunately, similarly with opiates, we've seen a good proportion of them, 41% of them are utilizing opiates for their pain. So again, demonstrating to that fact that, not having the access to pain care, fellowship trained pain care is detrimental to these patients. And we have patient feedback data that strongly suggests that, patients appreciate the process. They're satisfied with the process. Here's an example of feedback about one of our telepain physicians through the process. So really, the future of this, we're incredibly excited about this. The future of this is potentially expansions. There's a lot of sites that really want to partner and really need to partner with us, and there is really a potential for expansion, but really focus on quality and access, which is key. And as the infrastructure expands when it comes to pain care, we hope that the Telepain Care Center will expand and transition with the infrastructure. I think the real next step in terms of quality is to see how this affects the community's overall opiate utilization, and really that bridges us to helping curb the opiate epidemic. And then the last thing, which is very important to us, is how do we leverage the Telepain Care Center? Now, we demonstrated that we can leverage this to improve access, but how do we leverage this and technology to improve healthcare equity, right? So a lot of our sites, the good thing about this is a lot of our pilot sites, LIJ Forest Hills, the Division of General Internal Medicine, have a very diverse patient population. And we're very excited about really exploring how this can impact improving healthcare equity going forward. So this is brand new. A lot of what we're doing is brand new, but this is very exciting for us. We've never done anything like this, and there's nothing in the literature of a program like this. So we're incredibly excited to see, what the future holds, and really excited to see if you have any input with your vast experience and if we could partner in any way, shape, or form. Thank you very much.
Thanks, Dr. Huang. Nancy, hopefully that met your expectations. We're more than happy to hear the reactions from the attendees or any questions that they may have or comments.
Thank you both so much. That was awesome. It definitely met our expectations. I don't see any questions that came in on my end, but I know that some participants will chat questions directly to our presenters. So if you can both take a look on your end and see if there is anything chatted to you guys personally.
I just checked. I don't have anything that came directly over.
Me neither.
Okay, well, to all of our participants, now's the time. If you have any questions for the Northwell team, please add those either to the chat box or the Q&A, and we'll be sure to relay those to our presenters. And we'll give it a couple minutes. In that time, I'll just give a couple of quick updates just to give our participants a chance to add any questions in. But again, thank you so much for your presentation, for taking the time to be with us today.
So Nancy, I do see one.
Great.
Yeah, so one of the questions that come through is maybe describing a little bit about the teams that have helped in this process. And we come from a very large organization, and I'm sure it doesn't really make a difference if you have a large or small organization. It does take a village to get these things up and running. I know you have a couple of participants on the attendee side of things from our actual Northwell telehealth service, Iris Berman and Patrick McCarthy. We went to them in the initial phases to get an understanding of how to stand up a process like this, and combined with their efforts as well as our opioid management steering committee. We have stakeholders from anesthesia, from pain care, from business development. Yili, I'm forgetting probably so many people, but it really does take a village. And the reality is we were trying to develop this for sustainability, and knowing how large our organization is, picking pilot sites and being very measured in our approach, not to build something that would get widely used right from the get-go and then really drown us in terms of how to staff it behind the scenes. So I think it's really important to kind of infuse strategy in terms of who your stakeholders are, but also how you roll out something like this so that you can build it in an iterative manner so that it doesn't drown right away, and then all of a sudden people lose faith in the process.
Thank you. We did get one more question I'm seeing that came in, I think, just to me, so I don't know if you could see this, but it says, do you have data on how well patients feel their pain was managed?
That's a great question. So, I don't know if everyone remembers, but there was a Press Ganey question back in the day that asked patients upon discharge, was quote unquote everything done by your team to manage your care? And that actually has led to a lot of the overprescribing that we saw over time. In regards to telepain, we do collect some qualitative data from our patients. I think one of the things that we struggle with in terms of like the management of their pain or the acuity of their pain over time, the one thing we're struggling with is actually getting the completion of those post surveys. So this is kind of a mix of a clinical service, but then also trying to evaluate it at the same time. And we're struggling in the further outreach to get surveys completed. Folks will pick up our call to help navigate and to check in, but the actual completion of some of these surveys is one of our pain points, no pun intended, that we're trying to navigate. Dr. Huang, I don't know anecdotally if you would like to share, at least from your longitudinal patient interactions, what the feedback's been.
Yeah, to your point, Dr. Kapoor, and thank you for the question. you know, to your point, I think the challenges are trying to collect the data while we're trying to develop a clinical program. You know, if this was a research study, it would be much easier, right? So in this case, we're trying to go and collect the data at the same time. To your point, I think, and to the questioner's point, I think the next iteration and the next logical step for this is trying to demonstrate some of these outcomes around pain around pain control, or rather its effects on quality of life, right? Just the pain control, to Dr. Kapoor's point, is not necessarily appropriate and a quality indicator right now, but its effects on function. And the other thing is, like I had mentioned, its effects on opiate utilization. Now, longitudinally, to Dr. Kapoor's point, we've developed partnerships with physicians and other sites through this program that would never have been possible from across different counties. Connecting physicians and other providers from different counties, talking about the patients, weaning patients lower on opiates, and establishing care for certain patients that, again, would not have been possible without this program. So I think this augments a lot of what health systems, including ours, have. And I think, again, telehealth, I think when utilized, I'm sure everybody here knows, when utilized appropriately, telehealth is a fantastic tool. And we have data in pain management demonstrating just that.
Thank you. That was the last question I'm seeing on my end. If you both want to just take one more quick look at your chat, just to see if anything came in privately.
So nothing here.
Nothing here neither.
Okay, great. Well, I will include Dr. Huang and Dr. Kapoor's emails with the notes. So if anyone else has a question that comes up later or that they don't feel comfortable asking right now, that will be available when we send out the notes. And again, I just want to thank Dr. Huang and Dr. Kapoor for joining us today and for sharing their telepain program. Again, like you guys mentioned, this is really new and really exciting, and hopefully in the future we'll see it become implementing it up in the North Country in our region as well. I think hearing from you guys really may help our partners see the potential opportunities. So thank you both so much.
Yeah, Nancy, same here. Thank you for the opportunity, and we're more than happy to chat with whoever about this work. Obviously, there's a programmatic side to this, there's a common sense side of this, but there's also a very humanistic side to this. So we're more than happy to chat with anybody about this. Thank you.
Yeah, thank you for the opportunity, Nancy, and similarly, reach out if there's any way that we can talk about this partner, because I'm a big believer in that nobody knows everything, so working together is key.
And we have a lot to learn.
Yeah.
Thank you. We all do. Thank you again. And to just close out in the last few minutes of the hour, wanted to share a couple quick updates. November 18th, this week, is National Rural Health Day that we celebrate. And this week we will be celebrating our Telehealth Innovator Award winners that were announced during our telehealth conference, the summit this past September. So look out for our social media posts where we will be highlighting our telehealth innovators along with the other rural health champions from our region. NYSA, the New York State Association for Rural Health, will be hosting some events. I'll be posting the links in the notes for that event. And then HRSA is also hosting events throughout the week to celebrate rural health. So I will be sharing that with the group. And then in the notes, I know that we weren't able to hear from the Department of Health or OASAS during this call, but I will be reaching out to our partners to see if there were any updates that I can share with you all, and I will be sure to put those in the notes as well. Finally, the FCC has put out a couple of different notices in the past week or so. I don't know if you all have seen, but again, I'll put these in the notes with links, but the FCC did reach the $150 million benchmark for the COVID telehealth program round 2. So I will be touching the information on that, and as well as the note that the FCC announces over $700 million for broadband expansion in 26 states, including New York. So I will be including the link to that commissioner document that has some more information on broadband expansion. I will also be including a Center for Connected Health policy report that summarized the 4 webinars that they held during the fall on telehealth and Medicaid. And the report dives into the findings gleaned from the presentations and synthesizes key takeaways from each Medicaid agency's telehealth policy activity. So that's a great read and report to look out when you have a chance. So again, all of these, along with the CMS 2022 telehealth changes, will be included in the notes that I'll be sending either this afternoon or tomorrow morning. And with that, I want to thank everyone for joining us for today's presentation, and for Amy from OMH, Tony from CMS, and Dr. Huang and Dr. Kapoor of Northwell for their updates and presentation. Everyone, this has been the last Telehealth Learning Collaborative of 2021. And I hope to see you at our next call, which will be January 24th. Tentatively, we will be sending out, of course, reminders and a notice before the time. But for that, I will be sending out the notes, and hopefully everyone has a great rest of their day. Thank you all again.